Okay, good afternoon. I think we're going to go ahead and get started. Good afternoon, everyone. Welcome. I'm Fred Bronstein. I'm the Dean of the Peabody Institute, and it is great to see so many of you here in person, and also we've got folks online, so welcome to everybody. And we're especially glad, of course, this weekend to have the broader Hopkins community gathered across the divisions for All Alumni Weekend, and it's a great example of One Hopkins and the One Hopkins spirit. Over the last decade, I'll just share with you, Peabody has increasingly focused on arts at the intersection of health. And if you think about it, what better place to do this than at Johns Hopkins University? And at Peabody, we are thinking about this work in a very practical, what I would call two-pronged way. One prong is supporting the health of musicians and dancers themselves, especially injury prevention, performance wellness, and recovery, so artists can sustain long careers. The work has been largely the focus of the Johns Hopkins Rehabilitative Clinic for Performing Artists on the Peabody campus, which is the first of its kind in a conservatory setting. The other prong is how we thoughtfully integrate the arts into healthcare settings, partnering with clinicians and researchers to support patients, care teams, and families. And as an exciting next step in this work, Peabody is working towards establishing a new Center for Performing Arts and Health, our first academic center. And it reflects something that we are really proud about at Peabody. We're continuing to make strong strides in our core programming and performing arts training, while also building innovative programs that connect the arts to the wider world in meaningful and practical ways. Today's conversation is focused on that second prong that I'd mentioned and how music can function as a powerful, evidence-based resource for care, healing, and human connection, especially across clinical environments. And we'll talk about what this work looks like on the ground, what the research is telling us, and what it can mean for patients, families, clinicians, and our community. One of the things that makes this moment exciting is the partnership behind it, bringing together Peabody, the School of Nursing, and the School of Medicine. And these are three distinct lenses, and together they create a real continuum of music practices in healthcare: artistic practice, therapeutic practice, and music medicine research working side by side. We are lucky to have an amazing group with us today to carry on this conversation with people who represent the breadth of this field and the different ways music shows up in healthcare settings. So let's get right to it. Our conversation today will be moderated by Sarah Hoover, our Associate Dean for Innovation in Arts and Health at the Peabody Institute. Our other panelists include Lara Bruckmann, Arts and Health Program Manager at the Peabody Institute, Kerry Devlin, Senior Music Therapist at the School of Medicine, Junxin Lee, Associate Professor at the School of Nursing, and Jonathan Vogt, Sound Rounds musician and a member of the Peabody Preparatory Faculty. Finally, I want to thank all of our colleagues, performers, alumni, and friends who support this work as ongoing, and to all of you, of course, for making time to be part of this conversation today. And with that, I'm delighted to turn it over to Sarah.
Thank you so much, Dean Bronstein, for your introduction and also for your unflagging support of Peabody's expanding arts and health portfolio. It means the world. Thank you to the Hopkins Alumni Relations team for inviting the four of us to share our work. Thank you also to Jonathan, who quickly changed places, for sharing the beautiful music that you all heard as you walked in the room. Jonathan, I want to say to you that your music always helps me feel grounded and present, and I truly appreciate that. Thank you. My name is Sarah Hoover. I serve as Associate Dean for Innovation in the Arts and Health at Peabody. You've already heard the names of our guests today. I won't read them again. But I will just let you know that each will offer a unique perspective on today's topic, the sound of care, music meets medicine. A few words about this topic, just as a kind of overview for the discussion that will ensue. The connection between music and healing has been around from the inception of each discipline. They've been intertwined forever. And while music's role in healthcare is not new, it is gaining traction and maturing as hospital programs expand and diversify their services for patients and staff. Evidence for the efficacy of music interventions continues to grow, and diverse practices are increasingly professionalizing with better defined scopes and boundaries. Additionally, music is now being integrated not only into clinical settings, but also into community and public health contexts. There's a lot of activity underway. And you may hear a lot of different terms, just a few of which are music therapy, music medicine, therapeutic music, arts and health, creative health, neuro arts, music for health. This can be confusing. And I have to say that as a scholarly endeavor, but also a practical endeavor, coming to common agreement about terminology matters, because without it, it's hard to understand what's happening, who is doing the work, or who is qualified to provide safe, effective, and appropriate services to vulnerable people in healthcare settings. So today we'll focus on three perspectives, that of music as medicine, that of music as therapy, and that of music as connection. You will hear stories from each of our three panelists. We'll then dig into the practical and ethical issues in the panel discussion. We'll take some of your questions, and we'll conclude with a musical offering from Jonathan that he will specifically calibrate in response to what's happening in the room, which is his job. So I will now turn this over to Dr. Lee.
Thank you, Sarah. Okay, good afternoon, everyone. I'm Junxin Lee from School of Nursing, Johns Hopkins. So it's such a pleasure to be with our Hopkins alumni community here. My research mainly focuses on promoting sleep and cognitive health in older adults population in the community setting. Music-based intervention can be used to support many aspects of health, but I will only briefly share what in my research work, how we use music as a practical resource to support sleep and cognitive health. So music-based sleep intervention, I would have to acknowledge music intervention for sleep now is not a mainstream sleep intervention, but there is growing evidence support music-based intervention for sleep health, particular for my interest, particularly in older adults population. So these two graphs, just from a recent published book chapter I co-authored on music and sleep. So we reviewed literature in older adults population. We found like calming, low-tempo music, listening before bedtime, that result in better self-reported sleep quality, increased sleep duration, and significantly reduced the time for people falling asleep. At the same time, as you can see on the right hand, the graph shows, in research protocols, when we use music as medicine, music a lot of time, it's not a standalone intervention. It has been integrated with other already evidence-based sleep intervention. For example, you can see here like breathing exercise, light physical activity, and sleep hygiene education. And there are some research shows like when music combined with these evidence-based intervention, there are some synergistic effect actually make the other intervention effect stronger. So it's just to say, like for music, it doesn't need to replace any therapy, and working together, integrate together, it may improve other experience and also have a stronger impact. So building on that, I want to briefly share with you a research project we recently completed within my team, and focusing on brain health. So many of you may know the cognitive therapeutic effect of 40 hertz sound. However, one practical challenge is like the listening experience of this pure 40 hertz tone. I will try to play it. So you already heard the patient preferred music. So I will just tell you what I was trying to do, our team trying to do, is like, since the 40 hertz sound a little bit rough, so the initial idea is we use music to create something that's more enjoyable, and our older adults, they can tolerate more, and potentially really in practice, we can use it for a longer term to promote cognitive health. So what we did is combine the two, make the 40 hertz tone still audible, but at the same time use the participant self-selected music to keep some musicality and the musical enjoyment there. Oh, okay, again.
Someone told me long ago.
So we recruited our older participants. Then we gave them all three conditions, each for 4 weeks. Then after that, we interviewed them about their listening experience. At the same time, we assess their cognitive performance before and after each condition. So not surprisingly, and we found that our older participants, they actually did like our 40 hertz music better than the 40 hertz tone, the pure 40 hertz tone. And at the same time, we observe similar cognitive improvement compared to 40 hertz music with the pure 40 hertz sound. So right now we are seeking for bigger funding to replicate this in a larger study. And this is just an example in research how we use music to improve feasibility, adherence, and the experience of participants in research. So to close, so what I want to say is like music is so accessible to us, and it's already part of our life. With evidence, research evidence support, we can intentionally use it for certain health outcome, just a simple way to support our well-being. So that's all I have, and I will hand this to Kerry.
Hi, everyone. Ooh, this is making me feel quite short. I'm going to stand on my tippy toes. So my name is Kerry, and I am a music therapist by training and a PhD researcher working in the School of Medicine, specifically in neurocritical care, which is a really specific clinical environment. I hope to never meet any of you in that clinical environment. And I thought that the best way to talk a little bit about what I do as a music therapist would be to share a story. of a very real patient encounter. I'm sharing this with their permission. I'm going to use pseudonyms that the patients themselves selected. But I think it's really hard sometimes to conceptualize, how music can be used clinically to influence different kinds of clinical outcomes, especially when we're talking about a place in the hospital where I actually don't get to meet patients very often. I'm working with folks who are in coma, who have severe acute brain injuries, who have autoimmune encephalitis that might alter their ability to interact with other people, sometimes temporarily or for quite a long time. And my role as a music therapist is to use music as a tool to support their clinical and functional goals. So sometimes that might look like neuro recovery goals, so helping to support someone's arousal and awareness, to get them opening their eyes a little bit more as they're emerging from coma. And sometimes my work is very relational and very grounded in psychosocial and psychological supports. And so this is a real picture of one of our neuro ICU rooms. It's looking a little bare bones to me. Usually there's a lot more equipment in there. And so on the day that I met Babs and Brian, I met them in a room just like this, and their day had started quite normally. They woke up and they made pancakes for their 2 young kids. They exercised and got dressed and went to work. And by lunchtime, Babs was in a life-saving neurosurgery because she had experienced a severe intracerebral hemorrhage at work. And it was very catastrophic. She needed to be rapidly intubated when she arrived to our emergency department, and she needed immediate life-saving surgery. The impact of her bleed was pretty profound. If you've ever seen a picture of a brain, they're supposed to be quite symmetrical. And Babs's bleed was so severe and caused so much swelling, the center or the midline of her brain actually shifted, which can cause a lot of really, really difficult to manage sequelae from that initial bleed. And so when I first met Babs and Brian in this room, Babs was in coma, and her husband Brian was at bedside and was quite distraught. Obviously, it had been a really life-altering event that they had experienced. And Babs's medical team, her physicians, sent me to share space with them because they knew what a difficult moment this was. And their hope was that Babs was going to emerge from this coma. And so they invited me to go into the room and to share in music and to also support Brian as he was sort of grappling with what had just happened in their lives. And so when I brought up the idea of music, Brian's face lit up and he said, "We love 80s rock." 80s rock all the time. He said, "Can you play Separate Ways by Journey?" And I said, "Well, I didn't bring my synthesizer with me today. But what if we share in music that is highly preferred and meaningful to you and to Babs right now, because we want to see if music will have a positive effect on some of her clinical outcomes, like her vital signs, and we also want to see if music might help her come back to the world a little bit." And so the very first song I played was Faithfully by Journey, and you might know that part. Yeah, see, you got it. You're singing with me. So the first time I made music with them, I actually never sang more than those O's because Babs, her vital signs were quite easily stimulated. And so I offered just that simple little bit of music for quite a long time in tempo with her breathing to help her vital signs regulate. And then a few sessions later, I was playing Roll with the Changes by REO Speedwagon, and Babs opened her eyes for the first time. When music was in the environment, she had not demonstrated that skill clinically with any other provider. 2 sessions later, she started moving her mouth as I sang, "I'm all out of love." So she really liked it, kind of a little bit corny. And then the very last session, the 12th time that I worked with Babs, over 12 weeks, she was able to request a song herself. And Brian actually shared this feedback with our team, saying, music therapy helps so much with Babs's clinical outcomes, but also it helped us feel. It helped us connect. Sharing in these songs helped her make strides in her neuro recovery, but also helped us not feel like a patient, helped us feel connected as a partnership, and it really helped us feel hopeful for the future. But it did also have a clinical impact. This is a little bit hard to see, but we actually tracked Babs's vital signs over time, and we saw really positive trends in before and after music therapy sessions. Her heart rate was lower, which is clinically quite significant. Her respiration rate was much lower after music therapy sessions, so her work of breathing was less, which is significant as she's coming off the ventilator. And so our team, just in closing, our team was quite interested by how music therapy really impacted Babs and Brian. And so we've undertaken now some larger projects. We've developed some guidelines for safe music delivery in this clinical environment. We have a cohort of 69 patients whose vital signs we analyzed before and after music therapy and found music therapy had a stabilizing effect. Across the cohort, there were no adverse reactions to music, which is a really good thing in an environment where people have quite a lot of adverse reactions to a lot of things that are happening to their bodies. And so I hope maybe you'll scan this QR code and read a little bit more. Babs and Brian's story is actually shared in full in this manuscript. But my takeaway that I hope we'll come back to in discussion later is that music therapy is a clinical intervention, but it is also a humanizing intervention. It can bring opportunity to reminisce, to create new positive memories, and to strengthen relationships with the healthcare team as patients and families are facing really profound uncertainty during a neuro ICU stay. And it can also generate really important information for the healthcare team about how that patient might be recovering. So I'm looking forward to talking more with you about this soon, and I'm going to kick it to Lara now. Thank you.
Thank you, Kerry. Good afternoon, everybody. My name is Lara Bruckmann. I am the Arts and Health Program Manager at Peabody, so I work very closely with Sarah on the programs that she built and I get to now manage. I come to this work from a very diverse, broad career. I'm a conservatory-trained musician. I worked as a working musician for about 2 decades, and I'm also a nurse. I worked in labor and delivery, mother-baby for a while. I also worked in oncology research nursing at Johns Hopkins, and we can talk about how all of that happened later if that comes up. But then I found this, and before I move to the next slide, I'm going to ask all of you a question. How many of you are familiar with the Johns Hopkins campus? Been there a few times, right? I'd like to do a little experiment with you. Can you just take a moment to recall a time being there, or if you're not that familiar there, go to a medical place in your mind, like public spaces. What is it like walking around, going to an appointment or a meeting, trying to find something? How do you feel? How does your body feel? Do you feel welcome? How do you feel about the institution? How do you feel about the people around you as you walk through those halls and try to find your way? Now how do you feel? Have you seen something like this? Anybody come upon something like this over at Hopkins? These 3 areas, on the left here, this is at Jayhawk, right, at the Johns Hopkins Outpatient Center. And 2 of those are, and one is in the Weinberg building, the cancer treatment building. Now how do you feel? If you have not experienced this, maybe what you experienced as you came in today and heard Jonathan might give you an idea to imagine. It's one musician, not on a stage, no microphone, not playing at you, expecting your attention, demanding that you sit down. There's no audience playing with you, with the space, right? With the activity, people are still moving around. Now, can you imagine what it would be like and how it might be a bit different if there were a stage, if there were other players with them, and they were interacting with the other players, or if there were a conductor? Would it feel a little strange to walk in and there's a big audience there? Maybe now I'm invading something. But this feels like maybe it's just for you, right? It's kind of precious. There's something sweet about this. It's delightful. There's no concert hall rules. So this is the concept of the Music for a While program. Music in public spaces, calibrated to the context. Environmental music in lobbies. This is a student team trained to respond to what they're hearing, respond to what they're seeing, to acknowledge that their style has to adjust to what they're seeing. It's a public space, right? It's not their space. We're not there to make music. We're there to go to an appointment. There are certain social agreements going on in that space. So what happens impacts everybody there. They're paid for their time. They're in this scaffolded kind of training model. So people might decide to move on through. They might decide to sit and take some time with it, or not. Then this same thing can also move into a much more intimate setting. This program is called Sound Rounds. Here you see Jonathan. This is what he does when he's at work. Jonathan is here in rooms. These photos were taken with very deep level of consent. So know that these are being shared here after many levels of clearance, right? And these were actually taken by a photographer that was with us from the New York Times. Sound Rounds is a team of highly skilled and trained professional musicians. They play at bedsides and in shared spaces on inpatient units, so sometimes in hallways and near nursing stations. An in-room visit can look like a lot of different things. Very often a patient, that shared experience will start when someone on the unit, like a staff member, will let the patients know, oh, we have a musician who's here on Thursdays, and patients will kind of get the idea that somebody might come and knock, or they'll hear the musician playing out in the hallway and they'll get curious and invite them in. But then that encounter starts, but it always starts with curiosity and consent and a conversation. It might quickly move to something that looks like a performance, but there's conversation, and it's always led by what the listeners in the room are interested in hearing. It could be building playlists together. It could be conversations about favorite music. It could just be an opening, right? But this means that the musicians that are doing this have to be really flexible. They have to be able to play a lot of different kinds of music. Everybody that's there ends up being quite vulnerable. So the musicians that do this work, we meet every couple of weeks, and we have what we call artist rounds. The musicians in the Music for a While program have similar support, supervision, right? Like therapists have supervisors, we have supervisory sessions also. We get together, we talk about what's been coming up. Those are also training sessions. That ends up impacting the unit culture too. They become a part of the unit culture. Oops, I'm going to go back up here. Something that they're always getting feedback from their through QR codes. They have QR coded feedback surveys, and we're constantly getting really wonderful comments from unit staff and from listeners of all kinds. So we have years worth of feedback from those folks. We also have feedback from the musicians themselves. They are always, for each shift they do, they give us feedback, and also their statistics, just straight up statistics of how many encounters. Last year alone, this is pretty powerful. Last year alone, their impact, they reported that they saw 1,449 patients, over 1,000 family members and care partners, and 2,200 staff members. That's a lot. This also has a profound impact on the musicians. It has this impact of getting them kind of back to music as connection also. That's kind of the fundamental underlying principle here, that it gets away from the sensation of music as this competitive pursuit and athleticism and exhausting, and back to just sitting with other human beings and sharing the music that is the conversation in the middle of the room. Useful. So these are just two of the ways that we've been bringing music to Johns Hopkins Hospital, and it can be used in many other ways. The specialized skill set of an arts and health practitioner really is to use their artistic practice to access the artistry of others. So that's something that I think we can discuss a bit later, is the distinct practices that we have here is in the intention and the approach. So let's talk about all this.
So there it is. Good. Okay, you saw some really powerful examples of different kinds of integration of music into healthcare, all quite distinctly different one from another. And so I'm going to now ask some questions about the practicalities of how this works, as well as ethical considerations. I think you've probably already seen that there are many potential ethical issues that arise in this work. But let's start with the obvious question. Music doesn't just belong in the hands of the people that we've talked about so far, right? Music is something that we all have. It's a cultural and creative resource for us all, right? So how do you experience the power of music yourselves, just outside of your work and your research and your clinical care, and right? What relation does music have to health in your own personal experience? Who'd like to give it a go?
Well, now that I am not singing for a living anymore, most of my musical practice, when I first kind of came back to music as a practice in my life, one of the first things I did was I joined a choir. I joined Handel Choir of Baltimore, which has been a lot of fun. But on my kind of more, I've always loved porch music. The very first thing I did is I went and I bought a mountain dulcimer because I wanted to learn Joni Mitchell's songs that she wrote for mountain dulcimer off of Blue, and I just kind of figured all of those out, and now I play the mountain dulcimer. And then I bought a ukulele, so now I play the ukulele. So most of the music that I'm doing now, I'm playing sitting on my front stoop in Baltimore.
Thank you. Jonathan, what about you?
So it's working. I focus a lot on music and my physical health, actually from the relationship it has to pulse and cadence, and I'm a little bit of a nut when it comes to rhythm and trying to feel that deeper. And I notice a distinct calming effect when I'm anxious about family stuff or whatever is going on if I actually walk to a metronome, as nerdy as that sounds, and it's just makes me focus on my balance, and it kind of getting at the sense of calm that you get from going to social dance. There we have a great dance community also in the city, so I participate in that a lot, and it just kind of lifts me up right away.
Thank you. Junxin, what about you?
Yeah, so I will speak for this a little from my research. So when for my research program, I always go with the participants self-selected music, like the music they like. But also in research evidence, there are like a certain genre of music, certain type of music will best for a certain health outcome, right? So the way I go with it is if people, they don't really like the music, you select, they may not really listen to it. So you don't really have an intervention there. So for my music study, the design is kind of in between. We suggest some genre and also go with the personal choice, preferred music. Yeah.
Thank you. That's so important in this work. Yeah. Kerry, anything you'd like to add?
Sure. Well, I spend a lot of time in other people's music. That's the biggest thing I learned when coming to this job and working with people in the ICU is that, wow, there's a lot of music that exists on Earth, some of which is known to me and a lot of which is still to be revealed. And so I guess my response to this is it's the way that my clinical practice intersects with my own personal practices. Wow, patients have introduced me to music I never would have found otherwise. Sometimes music that's culturally located. Sometimes I've been working with a patient for a very long time who just had a life-saving transplant, and they have the coolest music taste. I've never heard of a single artist that they have asked to bring into our work together, but we've developed this cool ritual where every time I see them, they give me music homework. So they give me a song or an artist or an album, and on my way home from work that day, I listen. And then when I come back, I share my reflections and thoughts. Sometimes we'll actually play those songs together live. But that's kind of one example of how my own personal music listening practices have actually shifted and expanded as a result of being in music in so many different ways with so many different kinds of people.
So that really leads to my second question, which is how would you quantify how strong the appetite for music is within the healthcare environment that you all navigate? How strong? Is it strong? Yeah?
Yes.
Very.
10.
Stronger than the amount of staff we have to meet the need.
It is 1,000 strong.
So there are not enough people, there are not enough hours, there's not enough music. Is that what I'm hearing?
I know for me, I can speak on a typical day when I receive consult orders from physicians in the medical record. I can see about 45% of the patients who are actually referred to me for music therapy because I have to triage and make really difficult choices because I might be in a clinical encounter for 90 minutes. I might be with someone, if someone is actively dying, I might be with them and their family all day. I might only see one patient all day because I'm walking that path with them. But that means that, on a good day, maybe I see, or on a productive by traditional capitalist standards work day, I might see 5 people, but that's really hard most days. And so just speaking to the documented need, it's 50% for me, and that doesn't feel great.
Yeah. Jonathan, anything you'd like to add in terms of the strength of that?
Yeah, generally, when we end up on units playing, the sense is that folks wish we were there more days, longer, more often, and there's both a very intense appreciation from patients that we get to see or patients who are walking by. A lot of encounters can also be people coming out of their rooms and going on their lap so they can come and hang out. But also staff. Staff are there day in, day out, week after week, month, years, and it really changes up the rhythm of their week too, and they really look forward to us checking in with them and maybe singing their favorite song and stuff like that. So constantly we get stopped in elevators and people are asking, how can we get music on our unit? And Lara has a whole masterful document a spreadsheet. I forget what I called it the other day, but it's like the spreadsheet of power and of all the places that we hope to be in the coming year. And part of that is having more musicians and, yeah.
The desire is big. I get emails all the time from units that are interested in having sound rounds or music therapy or something. Please come help our patients have something better than nothing.
I'd love to pick up on that something better than nothing comment, because I think that's, there is so much, in my experience, there's just been so much push, please bring this, right? So if that's the case, and if, let's say, we still have limited resources and can't expand, are there any limitations to this, right? What are the red lights rather than the green lights, right? And how is it possible that music can also harm as well as do good, do benefit? And I would love it if, just for the purposes of getting answers for everyone, if you all could just briefly describe an instance, if you've got one, of where you've witnessed music to be harmful as opposed to helpful.
Well, a primary thing in this, and John, you're mentioning this spreadsheet, trying to help units understand what kind of musician might be appropriate in what kind of circumstance, right? If we're going to help bring a service to a unit, what's the patient population on this unit? What is the goal of this visit? What's the clinical situation of the patient? If the patient is intubated and unable to verbally consent to a musical encounter, then they need a practitioner who is prepared to hold that visit and to watch their vitals and to address a clinical need. If it is somebody who is there to hold space with them and to keep them company and to communicate and connect, if it's somebody who is going to try to augment sleep treatment, we've got that here, right? So but there are so many other things that we could be doing in partnership with each other and in partnership with other practitioners with a broader range of services too.
Great. You got to the next question. That's great. But I want to return to the harm question, because I think this is really important. It is really hard for people to, and trainees, right, both music therapists and musicians, to fully comprehend that in certain circumstances, music can actually harm rather than heal. So Jonathan, and then I know.
So I primarily come out of the old time and country Americana genre, and if any of you listen to that kind of music, you know that there is a lot of sad songs, and the songs kind of wallow in their own sadness and in a kind of nostalgic sepia-toned way that can be nice when you're feeling good and driving in your truck, but maybe isn't nice if you're feeling sick. And pretty quickly, I realized that I needed to really kind of look at my repertoire and be careful about what the actual subject of the song was. There was even songs that I thought were happy, and then I would get to the sad part and I'd be like, oh my God, this is such a sad song. And, just learn other songs or find ways to either have the right songs or have melodies or things that don't necessarily call up such a direct response, because that's going back to preferred music. Preferred music is huge because people are opting into something that they choose and they want. And that could also be preferred vibe. So it could be like, do you want something upbeat? Do you want something meditative? Do you want something with words or without words? And I constantly am thinking about the words I'm saying being very, very powerful, and recognizing that they might request something, but the thing that I pull up might remind them of something that's sad, or that it might make them feel less at peace and calm. And primarily what I'm trying to do in my work is connect to them and validate them as like a person who has creative desires, and that kind of acknowledging that is helpful. So I don't want to make them feel worse.
Kerry, I know you got something.
Yes. Oh, yes. So by nature of being a therapist working in an intensive care environment, and particularly in a clinical environment where people's brains are very much fragile, they're in an active process of healing. Sometimes patients, the way that sometimes neurologic recovery is clinically managed is by doing things that we might think are a little bit wonky, like keeping someone's blood pressure extremely high to mitigate their intracranial pressure. You're trading one thing for another. And so that means patients are often right on the edge of, they could be very easily overstimulated, or they could be presented with a stimulus that could negatively impact the recovery trajectory. They could show us signs that they're overstimulated. Perhaps, a well-intentioned family member might play music really loud in the room, like, my loved one loves this song, I want to be able to share it with them. But then they start to grimace and sweat, and maybe their heart rate starts to go up, and they might actually need medication to intervene in order to stop a really harmful cycle that's called neurostorming that can happen when our brains are really easily agitated. So that's like on the neurologic side, I'm thinking very carefully about, when I played that Journey song for Babs and Brian, I played it like a lullaby, and I was barely even making sound with my guitar. It was very, very quiet and very, very slow. And that was a quite intentional choice. Babs's brain was not ready for Separate Ways by Journey. That song goes way too hard. And, her brain and body needed time to get there. And the way that I was offering, the container of the music I was offering was very intentional, because I was working with her clinical presentation and also what her vital signs and her body were telling me about how she was receiving that stimuli. And that over time, the goal is to gradually titrate that up and make that more complicated. And as her brain is able to acclimatize to that stimulus. But also on the other end of that, I'm also sharing space with people who are dying. I do a lot of death work. That's part of working in an intensive care unit. And that's something that is really uncomfortable for hospital staff to talk about. We don't like to talk about how people die in the place where we work. And that music can provide profound resonance in those moments, but can also become a future trigger for that patients' loved ones and family. I mean, I think we can probably all think of a song that we have a negative memory association with. I know once I was getting an awake procedure, they were asking me my music preference. I melted down and couldn't think of a single artist, and the doctor said, okay, I'm going to put on Michael Jackson. And they absolutely blasted Billie Jean, and I cannot hear that song without thinking of the pain that I was experiencing in that moment. And that's quite the same for emotional encounters. And so maybe somebody wants to hear a song that's tender and dear and cherished, but we want to think carefully about whether or not we actually want to offer that song in the moment, because we also have to think down the road how that song will then be received. If that was once a source of comfort, we don't want to take it away, take that experience away from that person. So it means a lot of really careful conversations.
We have like 5 more issues that we wanted to bring up to you, and the time is flying away. So just know that we really wanted to talk about interdisciplinary collaboration. We wanted to talk about a continuum of musical care across these different levels of expertise and different practices. And we also wanted to talk, dig into some of the ethical considerations, which are numerous. So just, in part 2, we can talk about those things. But in order to be able to get some of your questions in, before we go to those, I'm going to ask each of you to think of a short statement of what your vision is for the future of music in care at Johns Hopkins. A short statement, okay? So you can think about that while we address a few questions from the audience, and then we'll Because we're here not only to report on what we're doing, but to dream about what this could look like in the future. So I think it would be great to hear from these folks about what that vision might look like. Okay, who's got a question? There's a question right here. Are we doing mics? We are doing mics. Fantastic.
It seems as though guitars are really important in this, and I take it's the portability and maybe the sound. As a pianist, it doesn't look like much of a role to play except in a hallway or something. I was wondering if you could say something about that.
Great question about the actual instruments themselves. Yeah, Jonathan.
So I also play banjo and some other instruments, and the guitar, one thing about it is, it has nice low tones. And it's also very versatile in that you can kind of shape shift a bit easier. It's not polarizing. The banjo, people have lots of assumptions about it. So whether or not you play it in the way that they assume that you might play it, or like people assume it's super energetic, but it can also be very mellow, is basically the gist there. So yeah, I've had to deal with that and think about instrument choice, but I think there's lots of ways that can look. That's what I have to say.
Yeah. I have about 3 keyboards in my sort of instrument library. Unfortunately, don't tell them. Infection control does not like the keyboard because you can't take each key off to clean it because then it would break the instrument. But we have negotiated some terms of agreement because I said, you can't take the keyboard from me because I work often with patients who themselves are pianists who want access to that instrument, and or it's a great fine motor tool. You know, if you're recovering from a stroke and you're having new dexterity issues, piano keys provide really good feedback, motor and kinesthetic feedback, because you get the press and release of isolating fingers to play keys. And so we have an agreement where I can bring keyboards to a patient's room where it lives with them for the duration of their hospitalization. So we have an instrument loaning library that is supported in part by donors and always is too small. Somehow. I have like 8 guitars and it's not enough guitars because we loan them out quite often. So if I'm not able to work directly with the patient, maybe I can get them an instrument so they can have access to that during their hospital stay.
The other benefit of guitar, particularly, not only its portability, but the fact that it can play chords or melody, right? And as the piano can as well, but it's easier to bring in and out. Do you want to speak to the range of musical instruments we've got going on in our programs?
Yeah, one of the fun things about instruments is placement. You can respond, an instrument can go in a place or in a situation. You work with the timbre, you work with acoustics, you work with the musician themselves can respond to situation. You use the range, you use repertoire, you use improvisation, long tones to experiment with what can work in a space on a certain instrument. Also, there are 2 Peabody instruments at East Baltimore, pianos. One in Jayhawk, one that we've just placed in the Wolf Street lobby that can be played by anybody who would like to sit down and spend some time on it. So if you are over at the mothership and have a little bit of time to relax, there's a piano there.
We have another question. Yes.
So you described dealing with patients who were in deep coma, and I guess my question is, what's the neurological explanation, if any yet, for why a patient might respond to music as opposed to somebody saying, hey, wake up?
That's a great question. And actually, we do have some emerging literature that tells us a couple of things about how people in coma respond to different stimuli. There are sort of 3 known stimuli that can provoke a strong neurologic response in patients who maybe are in a minimally conscious state or might be in true coma, which means we wouldn't see like a behavioral response. They might look as though they're sleeping, but if we had them a bunch of electrodes on their head and we were looking at an EEG, we would actually see a response would be clapping really loud while yelling their name, so clapping and saying a person's name, and the music that people love, and familiar voice. So imagine what a music therapist coming into this environment might think when we hear those three things. I might play the music that a person really likes, encourage their family to sing that music to them, and embed their name in that musical stimulus. And so that's something actually our team at Johns Hopkins is hoping to further study to better understand what is happening neurologically for patients when we can't see a response, but we know that they may have a response. And actually 25% of people in coma actually have that. They have neurologic responses to stimuli as if they were conscious. We just can't see that outwardly. So this is like a very big future direction for my work and our team's work. So thank you for that question.
Thank you. I think in order for, we have three things that we need to do in the next 5 minutes. One is to take one more question. Another is for Jonathan to get his guitar. And the third is for you all to think fast about your future states. Okay, one last question.
So we got a question from our online audience.
Yes.
Robert wanted to ask, what are the effects of different frequencies on the brain? So you mentioned 40 hertz in your presentation, but he mentions 8 to 13 megahertz stimulates alpha waves. So do you use any other frequencies besides 40?
So for my research, I start using 40. Actually, the underlying mechanism is the whole gamma range that could be 30 to 100. But like with research evidence, mostly from animal research and early human research, like 40 hertz compared with other frequency, that's the most effective frequency to evoke the 40 hertz, the gamma brain activity. So that's why we chose 40 hertz. Thanks.
Thank you. Jonathan. Yeah. This is the moment. So we asked Jonathan if he would offer something musically as a response to the conversation we've had and the situation in which we are, the vibe in the room, and to do that in a way that's responsive to what he's perceiving in the situation. Yeah. That's up to you. You're in charge.
Well, because there was so much talk about Journey, I thought we could do something that we all know and love, because I think preferred, preference is great, and if people know the song, it's even better. So I encourage you to sing along.
get my fill. Everybody wants a thrill. Paying anything to roll the dice just one more time. Some will win, some will lose. Some want to sing the blues. Oh, the movie, it never ends. It goes on and on and on and on. Strangers waiting up and down the boulevard. Their shadows searching in the night. Y'all can sing it if you want.
Thanks so much. We are at time, and so we just really thank you for being here with us today, sharing this time, and we hope that you'll continue to stay in touch as these programs keep growing.